I don't think I need to introduce our speaker today, since she's professor of everything. And you all know her well. But we're going to talk about sepsis, which is an ongoing point of severe or significant interest to the critical care community. So, Laurie?
Thank you. Can you guys hear me in the back? My quality girls? Gotcha. Thanks, Carlos. All right, well, welcome to our annual sepsis talk for trauma, PI, and critical care grand rounds. Hopefully this will count for several grand rounds this particular year, and I won't have to do this talk too many times, but always welcome to do it because sepsis is my favorite of all the topics that we talk about. I have no relationships with industry to disclose for this particular presentation, but if there's any industry out there that would like me to join them, just kidding. We're going to talk about where sepsis was, go through sepsis 1, 2, and 3. We're going to go through the Surviving Sepsis campaign, the guidelines to where we started to where we are now. Talk a little bit about hemodynamic optimization for fluid guidance. That's a whole separate talk, but since it does pertain a little bit to what we're talking about, I will cover that. And I'm going to throw some other stuff at you that hasn't really made it for prime time yet for the Surviving Sepsis campaign, but things that we're doing here to treat some of our patients that I find interesting and kind of interesting for you guys too. So where do we come from with sepsis? You know, for years in MI, we treated septic patients. We treated septic shock, severe sepsis, and we enjoyed it. But one of the things that was always a problem is that it wasn't that disease process that anybody but us really cared about. I mean, you'd hear about all the money and all the research being done for heart failure, for HIV, for cancer patients. But you didn't hear anything about sepsis. But if you think about it, what are most of the HIV patients, the cancer patients, and some of the heart failure patients, what were they dying from? They were dying from sepsis. They weren't dying from that particular disease. And it frustrated one of my nurses to no end, to the point that, some of you heard this, she actually probably called Oprah 3 or 4 times, so I really think that there's still a restraining order on her for that. But once certain people developed sepsis and died from it, it became more mainstream and people really wanted to know more. They wanted to know why Superman the Pope and Kermit the Frog all died from strep pneumonia sepsis. They wanted to know why Patty Duke Austin died from intra-abdominal complicated sepsis. So people started paying more attention to it, and we started to learn more, and it actually made prime time. I don't know if Oprah still cares about it or not, but you know, hey, it's there. But one of the things that we see, this is a little older slide, but one thing that you'll notice is that despite the fact that everything that we've done, all the research, all the stuff that we did in the late 80s, early 90s, I mean, as a fellow, Steve, how many clinical trials did we do that we thought we had the silver bullet? I mean, I swear, we did anti-TNF, and I can't tell you, we did double-digit patients in the anti-TNF trial, and our numbers were great for survival, and we thought we had it pegged because we were blinded. We didn't know. We thought for sure we could pick the patients that were getting anti-TNF, that were surviving sepsis, and were doing great. Yep, those would have been the placebo patients. So no matter what we've done, the numbers are still going up. And although our mortality has gotten a little bit better, it's not where it needs to be. So where have we been to get to the point that we are today? Well, in 1992, the original Sepsis 1 came out in CHEST. And what they did was they took a survey of people throughout the world. And you either got it by mail, you got it by phone calls, or what have you. And they asked, hey, what's your definition of this? What's your definition of bacteremia, of sepsis, severe sepsis, multi-organ failure? Things such as that. And then they got together as a group at probably some very, very nice place. And they looked at it, and they gave us what the definitions were of all of these 6 terms. So that by the end of this particular article, when you talked about this disease process, everybody was on the same page. It wasn't like person X was saying that sepsis meant this and person Y was saying that sepsis meant that. Everybody was on the same page and was able to talk to each other, and we kind of had an idea. We also figured out what the sepsis quote-unquote continuum was. We knew what SIRS were. SIRS were the criteria for systemic inflammatory response syndrome. It was alterations in temperature, tachycardia, Again, I don't know where they got 90. We've all been taught it's greater than 100, but they chose 90. I can't help you. Problems with tachypnea, changes in PaCO2, anybody that's placed on a ventilator, BiPAP, something like that. And then alterations in white blood cell count. Now, one of the problems with SIRS, which we're going to talk about as we go through this, is that this is very nonspecific. Because I can ask you guys right now, go down 3 flights of stairs, go to the ground floor, run around the building once or twice. Every one of you, but maybe 1 or 2, would come in and you'd be meeting SIRS criteria. I mean, it's 100 degrees outside, right? So you'd be hyperthermic, you'd be tachypnic, you'd probably demarginate some white cells, and you'd be tachycardic. So everybody would meet criteria, but are you septic? No. So although we use SIRS for years, there are some problems with it, which we'll talk about a little bit further in. If you add SIRS to a suspected or confirmed infection, then you had sepsis. Add an organ failure to that, you had severe sepsis, and if that organ failure was hypotension requiring a vasopressor after proper fluid administration, you were considered to be in septic shock. So everybody's on the same page. We knew the continuum, we had the definitions, everybody was cool with that. As a matter of fact, we took it one step further, and when we started talking about organ dysfunction, Bob Balk wrote this article, and he identified 7 different organ dysfunctions. So we're all very familiar with the big 3, the big 3 being cardiovascular, renal, and respiratory. And when we get phone calls from the emergency department all the time, they tell us we've got a patient with severe sepsis or septic shock, and they always mention whether they decrease urinary output or whether they're on a ventilator, they're requiring vasopressors. But there's 4 other organ dysfunctions that usually don't get mentioned. Neurologic. Patients who they're confused, they have altered mental status. In the septic picture, that's organ dysfunction. Patients who have elevated liver functions. In the picture of sepsis, it's an organ dysfunction. And then you've got these 2 down here, which to me are super duper important. Metabolic failure. What's their lactate? And we're going to talk about lactate a little bit more later on. But if a patient shifts from aerobic to anaerobic metabolism, they're metabolic failure. It's an organ. And then right over here, when you take a look at the hematologic system, when I was your age, we had, well, not dicks, but when I was your age, when you looked at it, you either had septic shock with DIC or without DIC. Nobody considered that an organ dysfunction, but it is. And of very much importance is this right here. People don't really think that much about thrombocytopenia. As a matter of fact, one of the most predictive signs that you can see in a septic patient is their platelet count. The degree and the rapidity with which they develop thrombocytopenia is prognostic on how patients are going to go. So therefore, you actually have 7 different organs that you're looking at. And this is important for when you look at your patient's mortality. The higher the number of organ dysfunction that you have, the higher that patient's mortality. So if you get a 21-year-old that's got pyelo, develops sepsis, and they've got 3 or 4 organs down, that patient's severity is high. And you're going to get aggressive a lot quicker, as opposed to if you have an 80-year-old nursing home victim who has contractures, really hasn't been functional for 7 or 8 years, comes in with that. Well, you're going to shift more towards comfort care and goals of care with family. So knowing the number of organs and which organs are down is extremely important. Now, based on that, we followed that through for several years, from 1992 to 2001. Everybody was on the same page. People were speaking the same language. We knew the continuum. Treatment was still over here and over there and over there and over there. Everybody's still doing their own thing. But at least when we spoke with each other, we knew what we were talking about. In 2001, same group of people got together, added a few, subtracted a few, again went to a nice island, and they came up with Sepsis 2. In Sepsis 2, they added a couple things. The first thing they wanted to look at is they called it the PIRO staging system. And with the PIRO staging system, or PIRO, whichever one you want to call it, is it looked at 4 things: predisposition, insult, which is infection, response, and organ dysfunction. And what they wanted to do was kind of make it similar to our oncology brothers and sisters, in that when you look at oncology and you talk about different types of cancer, you always use your T&M system for that. You've got this type of cancer followed by a bunch of numbers. They want to do the same thing with sepsis. You know, we have a severe sepsis patient with a P2, I3, R4, O7 or something like that, so that you would know exactly the severity. Even though you knew what the definition of severe sepsis was, how sick were they? And by having the PIRO system, they were thinking, okay, great. It could kind of give us an idea where they fall in the severe sepsis diagnosis. Unfortunately, it's still around, but it never really caught fire, and people can still mention it, but nobody's really done anything with it. The other thing that they did was that instead of just saying that sepsis is infectious process documented or suspected with SIRS criteria, they actually expanded it greatly to look at different variables for hemodynamics as well as the organ dysfunction that we just talked about. And based on that, they're like, okay, we're still good with definitions, but the one thing we're not good with is that everybody's treating patients differently. So based on that information, the Surviving Sepsis campaign started out with the first article that came out was in Critical Care in 2004. And what they did was they pulled all the evidence-based medicine that they could find on the topic, went ahead, graded them, and type of evidence, and then graded the recommendations from there. And this was the first Surviving Sepsis guidelines. They took all the stuff that they looked at, and they gave it grades A through E. From there, they said, okay, well, we'll take it and we'll put it into the infamous bundles that we all know and love or hate, whichever one it is. And they gave it a 6-hour bundle and a 24-hour bundle. Everything they think it needs to be done in 6 hours, everything needs to be done in the first 24 hours. So not only do we have the definitions of these particular diagnoses, but we also have a treatment plan that everybody could follow. And when we talk about everybody following, the importance of this is not necessarily the academic physicians who are doing this 6, 7, 8 times a day, but more so a lot of times for the community docs that don't take care of all of this and they need some guidance, or some of the older physicians that aren't really up to date on the literature with what's going on. And for 4 years, people were starting to jump on the bandwagon. They were following the recommendations. So in 2008, went back through, again, looked at the evidence-based medicine, graded everything, put it all together, and they revised the bundles. So they took it and they gave them pretty colors, and they changed their names. They became the Resuscitation Bundle and the Management Bundle. But one of the things that we started to see was that most people didn't really have any issues with the 6-hour bundle. They were willing to do it. There wasn't a lot of argument about it, not a lot of questions about whether we should or we shouldn't. But until you got down here, then there were some questions. Should we really be measuring CVP? Should we be measuring SCVO2? What should we be measuring to check to see where our patient is from a volume resuscitation issue? But it wasn't enough really problems with this that people were still fine following the 6-hour bundle, the resuscitation bundle. The questions started to come in with the management bundle, that 24-hour bundle. And the reason behind that was because the original studies that were done, the original studies that were done, if you look at the first one looking at low-dose steroids, well, there are a lot of studies that have been done looking at steroids, but the study done by Anand and his group looked at 50 Q6 or 100 Q, it was 50 Q6 at that particular point in time and showed a significant improvement in mortality. However, when they came back and tried to repeat some of the studies that were done, it didn't show the same thing. It showed that there was no difference in mortality by giving the steroids. So people were starting to go, well, we shouldn't be doing it because you can't reproduce the data, it doesn't work, etc. But an article just came out, and I haven't had a chance to read it yet, I don't know if anybody else has or not, is that Anand just put out an article saying, and the title of it is, Why My Studies Were Accurate. And talking about utilizing steroids in sepsis. Steve, have you read that yet? Have you seen it?
No.
Have you read it? I haven't either. I printed it because I wanted to read it. So if anybody wants a copy, I've got it. I'll be glad to make you a copy. But yeah, I haven't had a chance to read it yet. But one of the things that if you look at this for its controversy, when he did his study, all of his patients were enrolled by 8.3 hours. All of his patients were septic shock patients. All of his patients were on vasopressors. The repeat studies that were done were severe sepsis or septic shock patients. They were done out to 24 hours, and most of those patients weren't on vasopressors. So there was a difference in level of illness at that point in time. So there was controversy related to that. Drotrecogin alpha, or Zygris, when it first came out, everybody loved it. Everybody jumped on the bandwagon. I don't know how many folks in here actually used it. I know I used it, and probably some of my older colleagues probably used it as well. But the thing with this was there was only one study. One study showed an improvement in survival. So again, people started questioning this. We need more studies. Can we reproduce the data, etc.? And then, of course, the infamous tight glycemic control, 80 to 110. Oh, it's too tight. Great, it works in surgical patients. Does it work in medical patients? Oh, let's redo the study. Oh, we did the study again. Oh, it doesn't work in medical patients. People went back and forth on it, and you had to actually read the data. But in medical patients, they're right. Between 0 and 3 days, tight glycemic control didn't change mortality. From day 3 on, it did decrease mortality, it decreased ventilatory stay, it decreased CRT usage, etc. So you had to actually read the fine print. And then, of course, the entire stuff with ARDSNet and all the controversies related to that. So this bundle, although it was still here, there was a lot of controversy with it, so that by the time we started looking in 2012, when, once again, it's kind of like the elections every 4 years, we're getting a new guidelines from the Surviving Sepsis campaign. By the time 2012 popped up, they're like, you know what? Zygris is off the market. We haven't, quote unquote, reproduced the other studies. Let's get rid of that 24-hour bundle. Let's just get rid of it. If people want to do that to take care of their patients, we're not against it. You guys do what you want to do from there. But we're going to focus strictly on severe sepsis in 2012, and we're going to make it a 6-hour bundle. And we're going to cut that 6-hour bundle into 3 hours and 6 hours. Patients, when they hit the door, you're going to measure a lactate, you're going to get blood cultures, you're going to give them antibiotics, and you're going to start pouring fluids into them if they're hypotensive or if they have an elevated lactate. Once you start doing all that, you try to do that in the first 3 hours, and then for 6 hours, if volume resuscitation doesn't work, put them on a vasopressor, measure something, whether you do CVP, SCVO2. And in 2012, you started to see the initiation of dynamic parameters such as stroke volume optimization, stroke volume variation, pulse pressure variation, things like that, starting to be here in the periphery. You started hearing people talk about that as being acceptable to do all in this part, and then, of course, remeasure your lactate to see if things were improving from there. Then the question became, wait a minute. What is this lactate of which you speak? Why are we measuring lactate in everybody? Well, if you go back to your first semester in physiology in medical school, remember when we started talking about the Krebs cycle, that basically an aerobic mitochondria is going to make 38 ATP per cycle. So therefore, if you look at supply and demand, as long as that cell is aerobic and it's making 38 ATP, it's like, bring it, man, I got this. I'm fine. But if you start hypoperfusing that mitochondria and you shift from aerobic to anaerobic metabolism, the next thing you know is you're making 2 ATP and that cell starts to fail. In addition to that, when you go through the cycle itself, you get water and oxygen at the very end in addition to your ATP. But if you get anaerobic, it doesn't go any further. It stops right here at pyruvate. Pyruvate then breaks down to lactate. Trying to measure pyruvate at the bedside is extremely difficult, so as a surrogate, we measure lactate. So lactate's a measure of the patient, of the cell's anaerobic state, and whether or not the patient is perfusing or not. And one of the things that's interesting is that, I don't know how many times you've seen it, but you've got patients that come in and they're on wide open vasopressors. They're pushing drug and they can't get their hemodynamics to improve. They can't get them to budge. And then somebody somewhere goes, hey, do we have a blood gas? And we check a gas, and the next thing you know is you look at their pH, and their pH is 6.7. Well, you know what? It's not going to work. Anybody that has an anaerobic or acidotic milieu, if you please, it's not going to work. You've got to get that pH greater than 715, 720 for any of these drugs to work. And that's why knowing what the patient's acid-base status is, knowing what their lactate, their base deficit is so important. And again, the easiest way to measure this is really just checking a lactate. And you can get them VBG, capillaries, blood gases, arterial blood gases. You can get them, respiratory will run it for you quick, or you can send it to the lab. And that information is important because it tells us if the patient's aerobic or anaerobic and kind of what direction they're going from a perfusional status. Now, one of the first articles that came out after all the stuff for the Surviving Sepsis campaign was the article by Jansen and their group, and they looked at lactates. They really did. They measured a lactate. If the lactate was greater than 3, they pretty much put it into the early goal-directed therapy protocol and said, boom, follow it on out. And they did. And they followed it out, and if their lactate improved by 20% or more after 2 hours, they discontinued the therapy. If it didn't, then they put them back to the top of the algorithm, and they started again. And what they found of interest is that it was very, very similar how they did it. Like I said, with early goal-directed therapy, as opposed to 0 to 6 hours, they did 0 to 8, as EGDT did 0 to 6. And what they found, again, fluids, red blood cells, inotropes, vasodilators, vasopressors, etc., of interest, although it didn't quote-unquote reach statistical significance. Look at the difference in mortality. You've really got almost 10% improvement in mortality in hospital. 28-day is a good 5%, and ICU is a good 5-6% from there. So just by following a single blood test, you were able to improve patients' mortality because it gave you an idea of what the patient's acid-base status was related to aerobic and anaerobic metabolism. Same thing is true when you look at this particular study by Putzgerich and their group. They did a really easy study. They measured people's lactate, they started resuscitating them, and then they remeasured their lactate a couple hours later. If their lactate normalized, their survival was 93%. If it cleared by 50%, it was 90. 10% mortality rate went up, survival went down. So just by following a simple blood test and trying to optimize that, we found patients improved clinically from that standpoint. But there are people out there in the world that believe in something called a MAP, mean arterial pressure. And we want to maintain a mean arterial pressure of 65 millimeters of mercury or greater. Now, there are pressure people, there are perfusion people, and there are people in the middle that kind of like to use both. This particular study by Hu-Wink and their group just kind of looked at that and said, if I'm volume resuscitating or I'm resuscitating my septic shock patient, what's their best chance of survival? And the answer is following your lactate, getting it less than 2, and maintaining a MAP greater than 65. If you can't get your MAP up, get your lactate down, and then go from there. This is your best outcome. So again, study after study after study shows that by correcting your acidosis and correcting your perfusion, getting an anaerobic cell aerobic, and correcting your lactate, you will improve outcome from there. And that's why when you see where we stand for the Surviving Sepsis campaign and the bundles and the CMS stuff, and when you get nasty grams from certain people that are in the room, they're not nasty grams. They're here to help you guys to get your patient's outcome to improve. And one of the things that we have to do is we have to follow our lactates and show that what we're doing is correcting them. And that's just some of the evidence-based medicine behind it. Now, one of the biggest controversies we have is fluid. How much fluid is enough? You know, when I was young and when I was an intern in the ICU the first time, I asked my upper level, I said, well, how much fluid do we give? And the answer was, just give them fluid until they gurgle. I didn't know what that meant. I knew it wasn't the right answer. And I didn't know if there was like a gurgle scale, you know, a little bit of gurgling, a lot of gurgling. I mean, I wasn't sure what that meant. But as I've gotten older, I realized that that was definitely not the right answer, and that we need to know where we are when we're treating patients as to how much fluid they should get. Because we found, for those that are still using CVPs, that the higher the CVP in this population after a certain number of days, the lower their survival. Same thing is true when we look at a positive fluid balance. You know, we ask you guys on rounds every morning, what's the patient I's and O's? Are they positive? Are they net even? Or are they net negative? What are they? It's important because we know that once we cross a certain threshold, if they're still positive, their outcome is poor. We can't just flood our patients. We can't just say, hey, make them gurgle. And it's important because you need to know where your patient is on their Starling curve. If they're right over here, going up on the upswing of the Starling curve, they're preload responsive, and they're going to improve their cardiac performance, whether you measure cardiac index, whether you measure stroke volume index, whatever you're measuring as your indicator of cardiac performance. As you're doing that, you know right here, they're good. They're going to get better. But once they plateau off here, giving them fluid is not going to improve their cardiac performance. They're actually preload irresponsive. And you know what? What you hardly ever see when you're looking at your Starling curve is, guess what? Your curve does this right here. And if you keep pushing them here, you're going to push them off their curve. And just like you get peripheral edema, just like you get ascites, you get pulmonary edema, you get the same thing with myocardial cells. They get edematous too, and the heart becomes non-functional. It just can't squeeze the way it needs to. So you need to know where your patient is on their curve. And once you know that, then you'll know how much fluid to give in each particular certain situations. Now, unfortunately, patients don't walk into the hospital and say, here's my curve. I'm here. You know, you are here with the red X on it. Unfortunately, they don't do that for us. And we also need to know where we are in that patient's care. There's 4 phases of our patient's care that we need to look at. The first is, are we in the rescue phase? When they're hitting our door, they're severely hemodynamically unstable, and we've got to put fluids in them, we've got to put them on vasoactive medications just to perfuse them to get them through those couple of hours. Once we get to that point, then we're in the optimization phase, where we can give them small fluid balances and try to optimize them based on where they are on their curve. From there, we shift into the stabilization phase, where we need to start thinking about stopping all this extra fluid that we're giving them and start stabilizing them and start diuresing them to get them off, then follow it by the de-escalation phase. So we need to know where we are. Not only do we need to know where we are on our patient's curve, but where they are in their disease process that we're seeing. Otherwise, they're going to end up there a little prematurely. So I mentioned early goal-directed therapy for you, and the reason why I mention it is because this is the study by Manny Rivers and Bryant Wynn, when they first did this, really changed how we practiced emergency medicine and critical care. Because like I said, I was told to give fluid until they gurgled. I didn't know what that meant. But this kind of gave you some direction in patients that presented with severe sepsis or septic shock. These guys were seen in the ED at Henry Ford, and then they were randomized to either the early goal-directed therapy arm or the control arm. In the early goal-directed therapy arm, they had a special catheter put in that measured CVP as well as SCVO2, and all this other stuff was monitored, versus the standard arm where they just had CVP, MAP, and urine output. The doctors in the emergency department saw them for the first 6 hours. And in here, they were volume resuscitated based on whichever arm they went into. At hour 7, hopefully there was an ICU bed, they shifted upstairs, but these docs were blinded as to what actually happened in the ED, and basically they just treated the patients per se. What they found was actually there was 103 cc's different at hour 72 between the early goal-directed therapy arm and the standard arm in the majority of patients when you did the average across the board. But of interest, they found that your mortality rate in the patients with EGDT actually was about 15%, 16% improved in hospital, 28-day mortality, and 60-day mortality. It was down to about 12%. Length of time in the vent, length of time in the ICU, infection, all those things were significantly improved with early goal-directed therapy. Now, based on that, people were like, we got to do this. Everybody's got to do this. The problem was putting in that special catheter that measured SCVO2. Not to mention that, most people didn't know what SCVO2 was. It's like, there's this new term that we're supposed to be measuring on these folks. One, as an ER doc, we don't want to put that catheter in. We want to make the diagnosis. We want to ship them upstairs. Problem with that was that by the time some of those people got upstairs, you're out of that window. So there was a lot of this going on with who's going to put the catheter in, who's going to measure it, and all that. And number two is, like I said, most people are like, I don't even know what SCVO2 is. SCVO2 is a measure of occult tissue hypoxia, and it will measure the patient's hypoperfusion before you're going to see hypotension in a lot of these patients. It's a lot like SVO2, which you measure through your PA catheter, in that it's a balance between oxygen delivery and oxygen consumption, and cardiac output, hemoglobin, oxygen saturation, oxygen consumption all play a role. The difference is where it's measured. SVO2 is measured in the pulmonary artery. It's an admixture of blood from the IVC, SVC, and coronary sinus. Normal 6 to 80, we say shoot for 70. SCVO2 is measured in the superior vena cava because the line sits in the neck in that particular place, and it measures an admixture of blood from the brain and the upper extremities. Again, say normal 6 to 80, say 70% is what we're shooting for. But when you look at SCVO2 and SVO2, the numbers aren't identical. As a matter of fact, SVO2 is about 7% higher than SCVO2. And the reason behind that is, remember, SVO2 blood has IVC blood admixed into it. And in the critically ill patients, what happens? The body redirects the blood to the vital organs: heart, brain, lungs, eventually kidneys. And where does it shunt it from? Skin, muscle, GI tract. IVC drains the GI tract, therefore it's less oxygenated than the upper extremity blood, and that's why you see a difference between SVO2 and SCVO2. And the study by Reinhardt and their group was really the first study that compared apples to apples when you were looking at SCVO2, because the individual patients had both catheters placed and blood was drawn at the same time, as opposed to the other studies where, 50% of the patients had SVO2 catheters, 50% had SCVO2 catheters. Same patients were their own guinea pigs from that, and that's where they got the 7% difference from there. Clinical applications, basically you put it in, see where you are, resuscitate from there, get them to 70%, and then you can follow it. If it starts dropping off, it's kind of an early warning system for something going on with your particular patient. Or if you just can't get them, you're stuck at 40%, no matter what you're doing, you need to go a different direction and try to figure out where you are from there. The problem with this was that, again, just like the Zygris trial, it was a one-center trial. And although I don't want to use the word revolutionized, but it revolutionized how we treated patients. And I remember, for a fact, we were in New York for a FCCM pre-meeting of some sort, and they brought in 3 or 4 different speakers for early publications before their publications came out. And Manny actually presented his data before this all came out in the New England Journal. And I remember, I was just fascinated by it. Steve, you remember going to that meeting? It was amazing. And the number of phones at that point, 2001, but everybody had their camera, and everybody's taking pictures of all his data because nobody had ever heard of this before. So it was revolutionary, and a lot of people jumped on it, and it became standard of care in so many places. If you go to HCA out in some of these outlying big cities that have all these massive hospitals, man, it was standard of care. And they were bringing people in to lecture on it and all that kind of stuff. Excuse me. However, there were a few people out there in the world, namely those at UPMC, who felt that it's a single-center trial. We got to do it again. Is it going to show us the same data? And the process trial came out. They looked at early goal-directed therapy arm. They had the standard arm. And then they had what they called usual care. Usual care was that arm where the docs just did what they usually did. They didn't have to follow SCVO2s or what have you. They just did what they usually did. And what they found was that across the board, there was no difference in mortality by using early goal-directed therapy. At that point, the guys at UPMC said, see, we told you, it doesn't work. The problem was this study was released 15 years after EGDT was released. They did the same thing down in New Zealand and Australia, except they used EGDT versus usual care. And then their data was similar. And then the ARISE trial, which was done in England, again, same thing, EGDT versus usual care. There was no difference in mortality. So based on that, there was like, nope, early goal-directed therapy doesn't work, you shouldn't be doing it, and a lot of hard feelings. This particular article came out last year where Bryant got together with some folks, and he literally took, and I use this, anybody who wants it, I've got it. It's a great review of all these studies together, all 4 of them. And he goes through and he lists all the enrollment, resuscitation endpoints, the different treatments, and all the different outcomes. And at the very end of it, I mean, and he's still a believer in it, and I am too. And my answer to you is this. In all 3 of these particular studies that were done 15 years after early goal-directed therapy was published, what is your usual care? I mean, if you compare your usual care to 1998 to what you were doing in 2015 or 2016, it's completely different. And it's different because when early goal-directed therapy came out, you adjusted what your usual care was. So when you compare early goal-directed therapy in 2001 to usual care, there was a significant difference. In 2015, 2016, when you look at early goal-directed therapy versus usual care, it's going to be pretty similar. Short of some of the questionable stuff with blood transfusions, it's going to be very similar. So that's why, in my opinion, I wouldn't expect to see a significant difference between the 2 groups because you should be doing that right now as usual care. What other ways can we measure where the patient is on their Starling curve? We talked about SCVO2. What about what we do every single day, 20 times a day? We get an ultrasound, we put it on the patient, and we see what their volume status looks like. One of the earliest articles that came out was done by Bobby Ayer and their group in 2004. They looked at respiratory changes on the IVC, and they compared it to the infamous CVP. And what they found was, from a specificity and sensitivity standpoint, looking at the delta IVC was much better than the 50-50 flip of what your CVP is going to tell you. And what they actually found in this particular study, that the change compression of 18% or greater was indicative of a patient who was preload responsive, meaning that if you gave that person a fluid challenge, then their cardiac index that you were measuring would improve. If it was less than 18% collapsibility, then by giving a fluid challenge, they're on their plateau of their curve, and they weren't going to improve that hemodynamic parameter. Now, we've talked about many, and there's several articles, I just don't have them all in there, but there's also those patients that you can't get through their IVC, either from a surgical reason, from a body habitus reason, you just can't get to their IVC. So what do? Look at their IJ. IJ distensibility, very similar. They actually compared it in this particular study to PPV, and look at that. It's just as sensitive, if not more sensitive. Again, looking at compressibility of your IJ. I can't tell you how many times we've tried to put a line in, and the patient's up like this, and we just can't get it in. You look at it because their IJ looks like this because they're so dry. So if you can't get to their IVC, just look at their IJ. And the other thing that we can do now is look at arterial pressure-based waveform systems. And basically, it's a left ventricular measuring device. It looks at left ventricular function, cardiac output index, stroke volume index, or you can look, and it looks at indicators of preload responsiveness. Depends upon which one you use as to what it will measure. All of them measure stroke volume and their optimization from there. This particular slide, just kind of a list of the major devices that were out there. Just in 2013, there's been a couple more added here and there. Truth of the matter is, I don't care which one you use. It doesn't matter to me. I don't have any stock in any of these particular companies. My answer is pick one, figure out how to use it, and know what the data means from that particular standpoint. And it'll help you a lot to figure out where your patient is on their curve. Are they preload responsive, or are they preload unresponsive from there? Study by Merrick and their group compared them all, and again, 80% or greater sensitivity from there. So the data, if you know how to use it, it will help you optimize your patient. Another thing that you're going to hear a lot about is PLR, passive leg raises. Very simple. Lift the legs. Whatever it is that you're measuring is going to tell you how are you measuring your stroke volume. using a flow track, you're using Lidco, whatever it is that you're using, where are they on their curve? If you lift their legs, do they improve their stroke volume or do they not? This particular study by Monet and Taboul, they put out, and it's really easy to do. One thing that I'm a little curious about is right here, they tell you, don't wake the patient. If you got a guy that's asleep with his head up and his feet flat out, and you flip him over and he doesn't wake up, I think you got a bigger problem than if he's volume down or not. So basically, lay them down, put their feet up, monitoring their cardiac, whatever indicator you're measuring. I use stroke volume index for mine. If there's a significant change when you do that, meaning that say your stroke volume index is 30, and you flip them around, and their stroke volume index becomes 35 after you infuse about 500 cc's of blood that's coming from the feet, the legs from there, then put them down, give them 500 cc's, and then repeat it. And when you get to the point where you have less than a 20% change in your stroke volume in doing that, you have stroke volume optimized your patient, and your patient is no longer on the upswing of their Starling curve. They've now plateaued. But please keep in mind one thing. Just because somebody is preload responsive, the only reason to give a fluid challenge is to improve your cardiac performance. If the patient's no organ dysfunction, normal lactate, making good urine, just because they're a little dry, you don't have to pour fluids into them. So you give volume to improve their cardiac performance if they need it. You don't give it just because you can, okay, if that makes sense from that particular standpoint. The last thing I wanted to mention just when we talk about optimization is the use of bioreactants. We have the Cheetah monitors. Guys, I'm really sorry to tell you, but if you put the Cheetah monitors on, you're not going to look like this. It doesn't help from that standpoint. So where do we go from here? So we've been doing all that. Next thing you know is you've got people telling you how to treat your patients, how much volume should we give them, this, that, or the other. My answer to this is if you've got a normal patient, no lung disease, no liver disease, no kidney disease, no heart disease, go ahead and give them fluid. Give them fluid till they gurgle. They'll pee it out. That's fine. But if you've got patients with lung disease, liver disease, heart disease, or kidney disease, give them fluid in increments and follow something. I don't care which one of the previous ones you follow something so you know where that patient is on their curve. And the reason why that's important is because in 2015, why they chose 2015 to finally put out the CMS Core Measures, knowing that the new definitions were coming out in 2016, is completely beyond me. But this is what you got to do. If you have a patient that presents with sepsis, get a lactate, put them on antibiotics, get cultures, and start your crystalloids infusion from there. You have to do it. It's a core measure. If you don't, people will send you nasty grams, and then your attendings will get nasty grams. If their hypotension resolves after some fluid, they're doing okay, excellent. Just remeasure your lactate within 6 hours, document it, and move on. If it doesn't get better, you got to do all of this over here. You've got to give them 30 cc's per kilo. No, I don't agree with it. I don't agree with it at all. I think that you should give them incremental fluids, see where they are on their curve, and go from there. Can you do that? Yes. You just have to document it, okay? You can't just choose not to do it, but not document it. You can document the patient got 15 or 20 cc's per kilo, and you stopped because when you measured the patient's IVC, it was non-collapsible and their SAT started dropping or something like that. As long as you document it, you're safe. And
all you have to say is resuscitation goals met.
Resuscitation goals met. There you have it. I'm meeting my resuscitation goals. If after you do all that and you give them the 30 cc's, you repeat your lactate, please document a note. Just do it. I know it sucks, but you got to do it. It's a CMS mandate. It's a core measure. We have to do it, so please do it. In 2016, although I really wish they would have waited a year, the new Sepsis 3 came out. New definitions, new criteria for both. Why? Nobody liked SIRS because it was overly sensitive and lacked specificity. And then they said that sepsis versus severe sepsis was confusing, which utterly broke my heart because anybody who knows me knows that severe sepsis was my favorite disease process of all time. But there's a couple articles here, this particular one by Kokkonen and this particular one by Chirpek, that shows some of the non-specificity of where SIRS came from. So from there, this is kind of how I felt the day they told me that we're doing away with severe sepsis. But the February JAMA article came out with a new definition for sepsis 3. SIRS was dropped. Sepsis is more than infection than SIRS. It involves organ dysfunction. And since sepsis is severe, there's no reason for severe sepsis. Boo hiss. Here's the definition. Sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection and an increase in SOFA score by 2. Okay? Septic shock. Same edition of JAMA. Septic shock is a subset of sepsis, profound circulatory, cellular, metabolic abnormalities associated with a greater risk of mortality than sepsis alone. These folks are volume resuscitated on vasopressors and have a lactate greater than 2. And last but not least, the third article in that same edition of JAMA looked at different scoring systems, and that's where they went into utilizing the SOFA score. And the SOFA score really just looks at 6 of the 7 organ dysfunctions that we talked about for severe sepsis and gives them, as they worsen, a 0 through 4. And the only reason it doesn't include lactate is because you're already measuring lactate as part of your definition. So they also came up with something called a Q-SOFA, which is a quick screening mechanism. Looks at hypotension, altered mental status, and tachypnea greater than 2 is an indicator that the patient is going to develop sepsis and have a poor outcome from there. Q-SOFA does not work well in the ICU, but is useful on the floors for predictability. Adding a lactate to Q-SOFA did not help in predictability in patients who are going to develop sepsis. Sorry, guys, I just love this one. So where we go with all that information that I've just thrown at you? Right here, sepsis 3, right there, okay? New definitions, new use of Q-SOFA to kind of go from there. This is just a summation slide. If anybody, like I said, if anyone wants my talk, just let me know, email me, I'll be glad to share it with you. Just don't give it, because then I get really pissy if people give my talk with my slides. But it's a good summation of everything that came out in February of 2016 from there. But there's been a few things that have come out since that I want to cover real quick, if you don't mind. And that's the use of hydrocortisone, vitamin C, and thiamine. I mean, we talk about it. We were very interested in it. This particular study by Merrick, when it came out, looked at 7 months before and 7 months after, retrospectively for 7 months, and then prospectively what they did. Treatment group, 50 Q6, vitamin C 150 Q6, and thiamine 200 Q12. And they did that for a minimum of 4 to 5 days. Mortality dropped from 40 to 8.5. PCT clearance improved from 34 to 86%. Vasopressor duration dropped significantly from 55 to 18 hours. And your SOFA scores dropped from 0.9 to almost 5, just utilizing this particular agent. These just show the same data that I just showed you. Now, again, single, isolated study. People said, cool, we want more. Well, I mean, to me, this particular article reviews everything and shows you exactly how easy it is and why vitamin C, thiamine work. I mean, it's right here. If you have any questions, data's right there. But the importance of this particular, why I show it to you, is because there are multiple studies that are planned or are ongoing right now that hopefully will show improvement in survival, decreased length of stay, vasopressor-free days, etc. The big two right now are the ACTS trial, ACTS, and the Victus trial. The Victus trial is getting there. It's close. It's not done yet, but it's close. And basically uses the same drugs, Q6 hours, for 16 doses, or death, or patients get better and get out of the ICU, versus placebo, blinded placebo, for Q6 hours for 16 doses. And they're looking at primary outcome as vasopressor and ventilator-free days, and of course they'll look at mortality, et cetera. It's not out yet, but it's probably, of the studies, I think it's ahead of ACT, the ACT trial. So I think this is one is coming, it'll be coming to fruition soon. ANG2 was released in 2018 after the ATHOS 3 study came, looking for another way to add to our sandbox of ways to treat vasodilatory refractory vasodilatory shock. The endpoint was an improvement in MAP after 3 hours of drug. Secondary endpoint was a change in cardiovascular SOFA score. And what it showed was that it did, in some cases, within 5 minutes, improve blood pressure and allowed weaning of the patient's vasopressor from there. It did not show any difference in mortality, but the study, ATHOS 3, was not powered for mortality. There are multiple trials that are ongoing right now to see if this is actual truth or is it a single study. So we're looking at it from there. Another thing that you're going to see that we use a lot is we use a lot of procalcitonin. When the original, the biggest trial that was done early on was in 2010 called the Prorata trial, utilizing a specific algorithm for when to start, when to stop antibiotics. Endpoint was number of antibiotic-free days and mortality. In this particular study, it didn't show any difference in mortality, but it did show significant reduction in antibiotic-free days, which correlated to the study done by Balk and their group in 2017 that showed a decreased length of stay, decreased antibiotic-free days, and significant cost savings utilizing procalcitonin in treating with antibiotics. The study was used also by Self and them in the ER. I mean, how many times you get patients coming in, is it viral, is it bacterial, is it COPD exacerbation, what have you? They checked a procal, and procal is one of the best predictors of bacterial cause of infection versus something else. And last but not least, the Moses trial, which I really liked, was showing clearance. If you were able to clear your procal by 80% within 96 hours, your survival improved significantly. If you couldn't clear your procal, which means you weren't clearing your bacterial infection, your patient's mortality went up from there. And this particular article, it just came out in Chest, 2019. It was actually a pro-con thing, back and forth a little bit. Haven't gone through all the really fine details of it yet, because like I said, it just came out, but I include it for you because it shows all the studies that have been done looking at procalcitonin, and the bulk of it favors the use of PCT in treating patients with antibiotics and when to start. 2017 surviving sepsis guidelines here, what used to be, what is no more, and what is expected from there. And then one other thing that just came out, I mean, I just saw this like 2 days ago, is utilizing the Mottling score to help predict mortality in our septic patients. They use it time zero, they measure time zero, they measure 6 hours, 12 hours, and 24 hours. For some reason, 6 hours seemed to be that best marker for them, and it showed, as you would expect, the higher the score, the more modeled the patient is, the worse their outcome, the higher their mortality is from there. Again, brand new, just came out, I mean, like 2 days ago. Haven't gotten a lot into it, but I wanted to include it for completeness sake for you. And last thing to tell you, 2018 bundles, 2018 update, they took everything that we once had, put it all in one itty-bitty bundle. Here's your new bundle. Measure lactate, remeasure if it's greater than 2, get blood cultures, give broad-spectrum antibiotics, and remember, you've got to give your antibiotics, but you've got to get your cultures as fast as possible, because there are some people that will clear their infection within hours, an hour or so, and you'll miss it. Not that you're going to change your antibiotics, but you know the best thing about it is if you get your cultures, you give your antibiotics, your cultures come back, you can de-escalate. So you've got to do cultures as quickly as you can, and then antibiotics. But trust me, if there's a delay, your patient's got to go to CAT scan, the patient, we can't get cultures, we just can't stick them, they need a central line. Whatever it is, don't delay giving antibiotics. Give them as fast as possible. You want to do all this within the first hour, but get your cultures as fast as you can, and then begin resuscitating your patient. If while you're resuscitating your patient, the lactate's up, the MAP is down, they're still hypoperfused, go ahead and put them on a vasopressor. Don't wait to give them 30 cc's per kilo and then go, oh, they're still hypotensive, and then put them on a vasopressor. If you got to do it, put them on a vasopressor while you're volume resuscitating them. You could always wean it off as you need to for there. And that's it, man. 150 slides. Thank y'all. Any questions?
No, I got questions.
You already know the answers. That's not fair.
I use and I teach SCVO2 monitoring.
I know.
And it has nothing to do, it has to do with the results of the process trial. The process trial was subject to the Hawthorne effect, which is a bias introduced by the fact that you know that your patient is enrolled in the control arm, and you're very subject to provide the best care that you can because you're not blinded to that patient. If you look at, in this institution and other institutions I've seen it, usual care in the process trial is not the same as usual care that you see here. There are delays in diagnosis. There's inadequate resource implementation in order to treat these patients. So SCVO2, I think, provides that you're stepping up that treatment
I agree.
a notch. The other thing, there's a recent study that came out that showed if you don't, it's similar to clearance of lactating procalcitonin. If you don't improve your SCVO2, your mortality is higher.
Exactly.
And so it's not just the initial resuscitation that SCVO2 is important, it's to make sure that over the next 2 or 3 or 4 days they maintain their SCVO2.
Yeah, and one thing also to keep in mind with that is in the early days when all this came out, everybody had to use the special SCVO2 catheter. That's not true. You put a central line in the IJ or the subclavian, you can draw an SCVO2 and measure it from there. It's just not continuous like it is with that special catheter. And it has been shown, actually, there was a study that was done by Jones and their group that came out early 21st century, don't know the exact year, did show that there was significant survival with continuous versus intermittent. So if you've got a patient that you know that you want to follow, put in a precept catheter so you can measure your SCVO2 continuously. And it's the same monitor that we use for our flow track devices. It measures continuous SCVO2 from there. Thanks, y'all. Appreciate your time.